Okay, I'm going to do a case 1 review. Case 1 essentially is the combination of an incidentaloma, a thymoma, and post-cardiac injury syndrome. First, I'm going to walk through the case really quickly, and then we're going to cover some of the high points. But first, I got to brag on my daughter. This came in the mail. She took her preschool screening in July, and we got this in the mail. It says she passed her screening, and the child scored above the cutoff, may be gifted or academically talented. Proud dad right here. And here's the super smart girl right here. Super smart and super pretty, and this is her first day of preschool in this picture. So we had an elderly woman, and she came in with the chief concern of tingling in her fingers, and she had a positive Tonnelle Sign over the cubital tunnel. She said, "Hey, wait it out, see what happens," and nothing got better, so she came back. She was going to get the surgery to have the cubital tunnel released, and so she had to get an X-ray. X-ray showed an anterior mediastinal mass. It pointed out in the case that she was a non-smoker and negative PPD. Okay, so the physical exam findings, we're trying to work up this anterior mediastinal mass. She was obese. She had Heberden's nodes on her fingers. CBC was all normal. Serum chemistry showed high cholesterol, modestly elevated LDH. Everything else was within normal range. CT, a large anterior mediastinal mass. Her FVC and FEV1 are all within normal range. So this mass, even though it seemed to be pretty large, it wasn't affecting her pulmonary function at all. So instead of getting the cubital tunnel release, she goes into surgery to have the mass removed. The mass was adherent to the pericardium, and the part that was adherent to the pericardium was excised and replaced with a patch. So during the post-operative period, she had a few episodes of AFib. She was giving digoxin, metoprolol, verapamil, quinidine, and warfarin, all to treat for that, and then she was discharged on these meds. The surge path report said, hey, we got an encapsulated thymoma. It was this size. All the margins are free of tumor, and all the lymph nodes are free. So successful surgery, successful resection of a potentially bad tumor. Now, she was kept in the hospital for some time because of the AFib and everything, but then she was discharged. And then 3 days after the discharge, which I'm pointing out this is in the range of weeks to months after her surgery. So 3 days after discharge, she reported with shortness of breath. She had paroxysmal nocturnal dyspnea that turned into outright orthopnea, ankle edema +1 bilateral, no calf or thigh tenderness or erythema. There was a non-productive mild cough, and her elevated respiratory rate, blood pressure 155/88, so pulse 100, and then a temperature of 38. There was no JVD sitting up, but there was jugular venous distension at 45 degrees with no hepatojugular reflux. And so just to kind of refresh your memory, you'll remember that the JVDs, typically whenever you have backup in the portal system, it can cause, because of that, drain straight into the inferior vena cava, and then you have the jugular vein draining straight into the vena cava. Then all of that backing up can cause jugular venous distension, and typically both things can be caused by right-sided heart failure. On exam, so there's dullness in the bottom 1/3 of each lung field on percussion, and there was a normal S1 and S2, no murmurs, possibly an S3, but it was hard to discern. Pulse ox was 88%. So at this point, with dullness in the lung fields, we're looking at, okay, what's in the lungs, and typically we're like post-surgery thinking possibly hemothorax or something like that. There could be bleeding. There could be effusion. There could be a number of things, and so we just want to work that up. Okay, on the labs, it showed there was a bilateral pleural effusion, basically just sucking out some of the fluid and checking. The white blood cells were elevated in the labs. The PT and INR were increased. The PTT was normal. Now you remember that she was discharged on warfarin. Warfarin affects factors 2, 7, 9, and 10. Now you'll remember that factor 2 is the common pathway. Factor 7 is the external and then the internal. And the the PT/INR measures the external and common. And the reason that the internal is not really affected by warfarin, it's not affected by warfarin, is because factor 7 has the shortest half-life of all of these factors that are affected. And so factor 7, and it's best measured with the PT whenever you're on warfarin. Now her sodium was low. She had an elevated BUN or BUN, glucose, and LDH. The BUN creatinine ratio was 21.8181. So what we're probably seeing is decreased perfusion of the kidneys, maybe due to decreased cardiac output, and so we want to work that up as well. Then we got the urinalysis. The urinalysis showed a specific gravity of 1.010 and negative for everything else. Now, I would just like to point out with this specific gravity, it's indicated in the Campbell and Walsh's urology chapter, I think it's chapter 3 or 4 on urinalysis, that anytime a specific gravity is fixed at 1.010, fixed, that means you would have to stay that way for a long time, which would mean you would require more than one test. Anytime it's fixed at that, it indicates renal insufficiency. And I don't understand the exact mechanism of this. I don't know if anyone does, but there's also an article on the Medical Library of Utah that talks about the specific gravity, and it says that in an end-stage renal disease, the specific gravity tends to become 1.007 to 1.010, so correlating with what Campbell and Walsh say. Now, just to elaborate on this, just for your specific reference, Campbell and Walsh say that a specific gravity less than 1.008 is considered dilute, and a specific gravity greater than 1.020 is considered concentrated. So even though the range is 1.001 to 1.035, above this you're concentrated, below this you're diluted. And I say all that as a correlation to the case, even though it didn't come up as an issue or anything like that. The ABG was done, pH was normal, PCO2 was elevated, PO2 was low. That makes sense, she's having breathing problems. Now the ECG was done, it showed a normal ejection fraction, which is greater than 45%, and greater than or equal to 45%. There was a trace mitral regurg and a small pericardial effusion. So, and there was also noted a large pleural effusion. So basically these three things are going to be the rest of the case. But anyhow, we'll go on. Thoracentesis showed exudative effusion. No bacteria was found on the gram stain or the culture. DVT was found in the ultrasound, but the VQ showed that there was a low probability of pulmonary embolism. She's on warfarin. She shouldn't have a pulmonary embolism. She shouldn't even have a DVT, but her score on the DVT, as we'll see later, her score is pretty high. She's had recent surgery, recent cancer, this kind of thing. There was a test for ACH receptor antibodies. It was negative. Her ANA was 1 to 80, but negative for all the normal stuff. Even though she was negative, because she had a thymoma, she was given the edgerthonium test. It had negative findings. And then they did serum antimyocardial antibodies. They're 1 to 40. Pleural effusion antimyocardial antibodies, 1 to 80. So we see in the pleural effusion, there's an increase in antimyocardial antibodies. So something's going on with these antimyocardial antibodies, we're assuming, that's causing this pleural effusion. Of course, post-cardiac injury syndrome is a common cause of pleural effusion. Or it's not a common cause, but it is common to get pleural effusion with PCIS. Now, she was diagnosed as a post-cardiac injury syndrome. Treatment was prednisone. Her symptoms fluctuated just like with any autoimmunity, and her medications were adjusted and fluctuated just like you have to do with any autoimmune disorder. And she never actually received her cubital tunnel surgery, so I feel bad for her. Let's do a quick anatomy review for the stuff that's important to the case. Right here you can see we're looking at the biceps, the biceps aponeurosis. We've got the brachioradialis. And you'll remember the next three is pass, fail, pass, fail. So this is pronator teres, this is flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. Nothing that is particularly high yield. Right here we have the median nerve. Then you come over here and you can see that the pronator teres, the pronator teres right here has been reflected, and underneath of that we can see a little bit more of the median nerve as it goes in, and then you'll see down here coming around from the back side that we have the ulnar the ulnar nerve. And then on the posterior side of the arm, I've gone ahead and depicted for you. Here's the humerus, and here we have the condyle, the medial condyle being right here, and the ulnar nerve coming down and going right around the medial condyle and into this little tunnel that's created by an aponeurosis. The aponeurosis is from the flexor carpi ulnaris being blended with the antebrachial fascia, so it goes right down in there, and at times it can get trapped, or it can get pressurized or hurt. And so these nerves travel all the way up to the hand. Up here we have the median nerve dorsal branches. Right here we have the radial nerve, and so we got the radial nerve coming up to here, median nerve up here. Right here we have the cutaneous nerve, or it's part of the radial nerve, and then right here is the ulnar nerve, and the ulnar nerve you can see comes up and does all of this right here. And so this part of the nerve is coming from radial, and this part is coming from median. And so again, over here you see that we have the ulnar nerve, and it's coming underneath this ligament here. And then right here you have the median nerve going up through the carpal tunnel. So here's a view of basically looking at the carpal tunnel and everything. And you can see up here we have the ulnar nerve. It doesn't go through the tunnel, but here we have the median nerve, and it does. So just knowing and understanding all of that with respect to the hand. Okay, let's take a quick look at the mediastinum now. So the mediastinum, you can see we have mediastinum here. It's broken up to superior and inferior, and the inferior is broken up basically into the anterior, the medium, and the posterior. And so the superior, you can see we have up here the thymus, the great vessels, the esophagus, that kind of thing. Then in the inferior, we have anterior, which is thymus, then middle, which we got the pericardium right in here, and roots of the great vessel you can see coming out of the heart as well. Then the posterior you have, which can't be seen on this, but you have the aorta, the ductus, the esophagus, the azygous vein, and that kind of thing. And so another look, we have the anterior mediastinum, the superior mediastinum, the posterior mediastinum, the middle mediastinum. And again, the thing to think about is what's up here. You're going to have a thymus up here. You're going to have close to the spine in the back. You've also got the esophagus and stuff. Then up here, you've got all the stuff coming out of the heart. And just here's another picture if you want to pause and kind of study this, knowing where the thymus is and stuff. And some interesting stuff, like here's the retrosternal fat pad, got the thymus here. And then again, the other thing we want to look at is where everything is. So one more time, we've got the thymus right here with the vessels around it. We've got the heart covered in the pericardium. Then here you can see the outside surface of this pericardium is called the fibrous pericardium. The inside surface is called the serosal surface. And then you have, okay, so the serosal surface is really talking about this inner surface of the pericardium as well as the surface of the heart. So the serosal surface is broken up into this parietal pericardium and this visceral pericardium. So again, we have the fibrous pericardium, the parietal pericardium, the visceral pericardium, and these two, the parietal and visceral, make up the serosal pericardium. And again, I think it's important to know where all this stuff is in relation to the lungs and everything. So you have the pleura as well coming around, and so pointing out that the thymus is not inside of any potential space, actually. So you have the potential space of the lungs, and you have within the heart a potential space as well. This is outside of all of those pleura. I just want to say a few more things about the anatomy before we move on. And the first thing is Heberden's nodes. If we're looking at the dips, the distal interphalangeal joints, if you got basically bony growth sieve, it's called the Heberden's nodes. And Heberden's nodes is specifically associated with osteoarthritis. So what I'm saying is, if you have osteoarthritis, you might have Heberden's nodes, you might have Bouchard's nodes, or you might have both. So Heberden and Bouchard. So Bouchard is the proximal interphalangeal joint, so the PIP. So we got the dip and the PIP, and the proximal nodes there are called Bouchard's nodes. And Bouchard's nodes can be seen in osteoarthritis and in rheumatoid arthritis. So if you have Bouchard's nodes only, you're not sure yet if you have rheumatoid arthritis or osteoarthritis. You need to know more. You need to do a further workup. But if you have both of them, it's probably just osteoarthritis. And then lastly, we saw the Tonnelle sign. Tonnelle sign, basically you're tapping on a nerve. It doesn't have to be any specific nerve. It can be tapping on any nerve. And if it causes a tingling sensation like pins and needles, then that's a positive Tonnelle sign. It means the nerve that you're tapping on at the place of irritation, if you're tapping at the place of irritation, then that is going to cause a positive Tonnelle sign. And so, for example, if you're tapping on the carpal tunnel and it causes the thumb and index finger to feel tingly, that means there's irritation in the median nerve at the carpal tunnel. And so for us, it was the ulnar nerve and it was the cubital tunnel.